Bienvenidos al webinar ¿Por qué es fundamental?
Welcome to our webinar on why it is essential to invest in mental health, organized by the Inter-American Development Bank. This conversation will take place in Spanish.
With simultaneous interpretation. If you wish to follow the presentation in English, click on the interpretation icon located in the toolbar at the bottom of your screen. Mi nombre es Marco Stampini. Soy parte del equipo de
I'm
protección.
Marco Stampini. I'm part of the social protection team at the IDB, and I will be acting as moderator today. First, I'd like to introduce Pablo Ibarrarán. He's a division chief of the Social Protection and Health Division at the IDB. Thank you, Pablo, for being with us. Thank you very much, Marco. Good afternoon, everyone. We know that the pandemic has had an impact on mental health. We've all felt it personally in our families and in our environment in general. All over the world, the prevalence of depression and anxiety have increased by 7.6% and 25.6% respectively, especially among women, health workers, and people who suffer from chronic conditions or psychiatric disease. But teenagers are not exempt. Young people and children are not exempt from this situation either. The situation is concerning for all of us, and our mental health issues are often mentioned as the next pandemic. We will hear about the moral and economic arguments as to why it is essential to invest in mental health and why this cannot wait. Dr. Araya will give us a presentation, but I'll give you one piece of information. 1 out of 4 people will suffer from some kind of mental issue during their lives, and this will cost about $6 billion worldwide. Where do we start? Are we investing enough in mental health? What can we learn in Latin America from the experience of other regions? And rather than just working to fight these diseases, how can we prevent them? At the IDB, we like to emphasize prevention, and we must do the same in this regard. I hope that this time will allow us to put some of these questions on the table and discuss them in a way that is open and that can help us, help guide us to make the best decisions. Thank you. Thank you, Pablo. Now we have the honor of having Dr. Ricardo Araya with us. He is currently working as a global mental health professor at King's College in London, where he was a director for several years. In 2022, he received the National Prize for Applied Sciences of Chile. We will have approximately 25 minutes for the doctor to give his presentation, followed by a question and answer session. We encourage you to ask your questions in English or in Spanish using the question and answer button provided by Zoom. Go ahead, please, Ricardo. Thank you very much, Marco, for your introduction, and thank you to Pablo for his introductory comments as well. I'm very happy that the IDB has decided to give me this opportunity to advocate for an increase in our investment in mental health. From my perspective, this is a very important endeavor, and my 2 colleagues made this very clear in their introductory remarks. I am trying to open up my presentation right now. Can you see my presentation on the screen now? No, we are now looking at your Zoom page that is open. I'm not sure why I'm not succeeding in getting into my presentation. If you have any problems, I can, if you have difficulties, I can share the presentation from here. If you would do that, that would be great, because I think now I can get in. No, it's not working well. I can share my screen and you can tell me when you want me to go on to the next slide. If I could get authorized by Ricardo, or Ricardo, if you could stop sharing your desktop, I will share mine. I want you all to know that I've been practicing how to do this. Stop share.
Si quiere dejar de compartir, stop share.
If you want to stop sharing, you can say stop share, or I can do this quickly. So the next presentation can be shared. Okay, now I can share my screen. Now, if you click at the bottom, there, that's perfect. Is it there? Great. My apologies to all of you, and thank you for your patience. I know you've devoted this half hour of your life to listen to some of these arguments, which I think are interesting and important. So thank you for your time for this discussion on investments in human health. I'll say something that might seem obvious, but it isn't always. The reality is that there is no health without mental health. And this isn't something I've come up with. This is something that is a part of the definition that the World Health Organization has established for the concept of health. And this was already 75 years ago, approximately. We've had this definition. It says that health is a state of complete physical, mental, and social well-being, and not merely the absence of disease or infirmity. And it's interesting, 75 years have gone by since this definition was agreed upon, and we still have to remind people that mental health is part of the definition of health. And in this regard, I'd like to make something very clear. The concept of mental health is quite broad, and it refers to the well-being of people in such a way that it allows them to live their lives, live full lives where they can be productive and can make contributions to society. It's a much broader concept than a view from which mental disorders are only the tip of the iceberg. When we lose this state of mental health, when people develop a health disorder, that is just a small part of what the entire definition of mental health means. Many of you might have heard about the Sustainable Development Goals established by the UN. When the UN proposed these Sustainable Development Goals, it also established some of the socioeconomic determinants of mental health. Of course, these apply to all the areas, but here we're looking at mental health. And here you see in this image that for any of these aspects, we can see how it can relate to mental health. There are elements and factors that have a significant impact on mental health. If you go to the bottom of it, you'll see that it mentions the neighborhood, where it talks about infrastructure, the presence of parks, transportation. All of this has an impact on mental health. And this has sort of stimulated or brought about the idea that in order to improve mental health, we need to think about taking action in an intersectorial way. It's not that easy, however, to sell the idea that intersectoral actions are necessary. And one of the elements for these initiatives is the idea that we want to improve mental health. And one of the reasons why it's not easy for people to understand this is that some of these socioeconomic aspects, when we modify them, there are profound political and economic effects. I gave an example. For example, when we talk about employment, there are elements here that are related to labor legislation, and these have an impact on mental health. When we think about urban development and housing, there are aspects here that also affect mental health, and other aspects such as policies, such as money transfers. And when we propose that intersectoral actions can have an effect on mental health, this brings about a discussion on whether investment should be focused on trying to provide better access and care for those who have mental disorders, or should investment on intersectoral actions focus on those social determinants of mental health. In reality, the discussion is quite complex. It's a complex matter, and it depends on your perspective. If you look at it from the perspective of the health sector, obviously in an investment on treatment is much more important than trying to look at these intersectoral initiatives that might focus on just the population as a whole. Ideally, from my point of view, we should think of it that this way. We need to achieve a balance when we make a decision on this type of investment. And multisectorial interventions, up to a point, if they include both elements, that would be ideal. We could have interventions where we do offer a treatment for a specific type of mental disorder, but this is tied to an aspect that is an intervention on a social determinant, for example, income through money transfers. Are mental disorders significant in the Americas? We know now that the main cause of disability related to all diseases comes from mental disorders. When this finding came up, it almost caused a revolution when people began to realize that mental disorders had such an effect on society. And about 20% of the total disease burden for all diseases could be attributed to mental disorders. It's very high in some countries. Among the adult population is the biggest cause of the disease burden, but we shouldn't forget about young people. The main cause of suicide and the second cause of death among youth 15 to 29 years of age is suicide. And this is a personal tragedy, of course. And in addition to that, it is a huge problem when we're talking about the young population, because that is the truncation of a life that would have had many years to make contributions to society. As Pablo said, when the COVID-19 pandemic started, it caused a whole series of issues with people's mental health. I won't go into the details, it's obvious why. But in addition to the reasons why prevalence rates of mental disorders increased, there's also another factor. Not only did this number increase, this also showed us what the reality was in terms of care services for mental disorders. And we realized as well, that as in the case of care for other types of physical diseases, we were not prepared. We did not have what we needed in order to be able to provide almost anything of use. Are we investing as much as we should in mental health in the Americas? I think this graph shows it all. I told you that mental disorders represent 20% of the total disease burden. How much are countries investing? This is not by any means a representative sample, but there are a few countries of the Americas represented here, and the average is below 2%. So let's look at this percentage, 2%. The total disease burden is 10 times as much as countries are investing out of their health budgets in this problem. And nobody will be surprised to look at this illustration, because with that level of investment, it's obvious that access to treatments for mental disorders is quite limited. And the truth is that in most countries of the Americas, 2 or fewer people out of every 10 people with depression receive an even minimally adequate treatment. So we are not providing coverage for what is needed. And when you try to give an argument as to why we should invest more in the area of mental health, there are two positions we can take. There's the economic argument and there's the moral argument or the ethical argument. The economic argument is one that we've seen many times for a long time, but for some reason it hasn't gained traction. It hasn't really gotten to the heart of those who make decisions on how to invest. 1 out of 4 people will have a mental disorder that they will face during their lives, as Pablo said, and this will have a cost of approximately $6 trillion worldwide by 2030. If we made the more adequate investment, this would definitely have an impact. And here I have some numbers. If we invested a few $billions, we could generate 23 million additional years of healthy lives during this period. And we always hear the argument as well that if we treat people who have mental disorders, their economic productivity will increase. And reality is that all of these are just numbers that we put on the table, that we throw out, but they don't really have an impact on how we can change this reality of how much we invest in mental health. In the developed world, a lot has been happening in the economic sector. Many are investing more. Businesses, for example, have begun to invest more in this aspect because they think, they have studied, they believe that an investment in improving the mental health of their employees will translate into some sort of benefit. And they see it from the perspective of a return on their investment, of course. We are now several different countries in the Americas looking at this and sort of joining this trend at different speeds. The moral argument, I would say, is the more powerful one, because the truth is that the right to health is a fundamental human right. And it has been recognized as such by the Convention on the Rights of Persons with Disabilities. And this in and of itself should be enough for governments, for states to focus more on mental health and make better investments to improve the mental health of their populations. At the same time, I've always been concerned about the idea that the economic argument, that argument about mental disorders negatively affecting productivity, this argument excludes those people who may not be productive at this time: senior citizens, the very young, children, people with disabilities. And in a certain way, this might contribute to inequalities that are quite marked already when we're talking about mental health and access to treatments. A lot is being said now about the mental health crisis. The World Health Organization, the Pan American Health Organization have both talked about this world mental health crisis. And basically, they're talking about the capacity that countries, societies have to address the problem of mental disorders. Is it a crisis really? Where I would rather say that we are waking up to this reality now. This is something that is now out in the open, and we are now beginning to realize what a huge debt we had in most of our societies in the Americas toward our people with regard to mental health. And now I'd like to focus on the idea of treatment. Is there something that can be done? The first great limitation when we think about what can be done is related to the fact that treatment of mental disorders is highly dependent on human resources, and human resources, especially people with a specialization, is something that we lack. We have a serious shortage. It takes a long time to train a psychiatrist. This person has to first be a doctor, then they need to study a specialization. It will take at least 10 years to train a psychiatrist, and then to make sure that that person will be working in the public sector health sector is a challenge. So we started to think, it's trying to skip over this slide, but this is one of my favorites. We have to think about how we can overcome this obstacle, the fact that we do not have the necessary human resources to truly address the problem. In the developing world, really, what has cropped up around this is the realization that we will not have that specialized human resource, and how can we take care of the problem with our existing resources. And in various countries, there are different types of resources. These are 4 examples of countries in the Americas where I have worked on this matter, trying to find a way to perhaps delegate certain tasks to others within the system. Here you see we have community health agents in Brazil. We have something similar in Colombia. Down below, there's a picture of a very nice project we had in Guatemala with women who are popular obstetricians. They are specialized in births. And now I'd like to give you a couple of examples of how some of this has taken place in the Americas. We have a program for depressed women in Chile. And then the second example shows us how we can bring in technology to make up for some of this shortage that we have of specialized doctors. In Chile, this is something that happened almost 25 years ago, and really this was a very unique project that has been replicated in many countries of the world after that, especially in African countries. And the only thing we did was to identify resources that already existed in primary care clinics. We trained this staff, people who were providing psychoeducational services, to give them a name. And these people were able to then provide another type of treatment in a way that was adequate in terms of quality for this type of treatment. And we saw huge differences after a few months, huge improvements in people. And then we did an economic study to see if this was something that the government of Chile could sponsor. And we realized that it was relatively inexpensive and that the government of Chile could cover this expense, which it did. And this became a national program that exists even today. And there are many benefits that when we do a research project, we are not aware that these benefits could be seen. And this was something very interesting that happened to us. We were simply working on a project to help women who had depression to clear their minds a bit, feel freer from this depression, and be again more similar to the person they were before, people who were able to do what they used to do in their environment. And there was a woman, after we withdrew from the project, these women in certain neighborhoods formed a group and continued to work in this way, providing support to other women within their community, other women who were suffering with depression, and they were helping these other women go through the same process. And it's been over 20 years since they started doing this, and they are still at it. It's a wonderful group. And it's a group that provides a very valuable service to its community. I just wanted to mention that as an example of what can be achieved when you help a person who suffers from depression to overcome that and go back to being a productive person that can make contributions to their community. The other projects we had in Brazil and Peru, it's more of a technological platform. We developed an app that allowed people who had depression and some chronic disease such as high blood pressure or diabetes. They were able to use this app, and with the help of a nurse, they were able to work on their depression. And the results, you see them circled in red, were very positive, especially in Peru, where almost 20% of them were doing better than the people who just were receiving the usual treatment. So these are just two examples of how this concept of transferring or delegating certain functions can allow us to address the problem and make up for the lack of specialized professionals. And in the short term, this is where I think it's important for all of us to advocate for this as a minimum. To advocate for a gradual but progressive increase in our investment, where we until we reach the same proportion as what mental health represents as our part of our disease burden. And we have to reach the same proportion as we do with physical diseases. Why is mental health still the poor relative when it comes to distribution of our budgets? And I think that primary care, having this sort of prevention in primary care, continues to be the most efficient way of doing it. And of course, we need to review our situation when it comes to human resources. But when we do, we realize that there's a lot we can do, even when we have a shortage of specialized professionals. And lastly, I wanted to mention that instead of fighting the digital revolution, we should embrace it. We should see what it can give us that can be useful to us as we seek to continue to promote mental health. So I encourage all of you to continue along this journey. Mental health is not just the responsibility of governments, it's the responsibility of all of us. We all have different responsibilities related to it in our daily lives when we see people in our own environment who have a mental disorder. It's our responsibility to help them, to promote the whole issue of mental health. Thank you very much.
Thank you very much, Ricardo. I do remember some years ago, I read that mental health is always the next big thing. The next big thing for public investment. And for example, the UK intended to invest heavily in mental health before the 2008 financial crisis, but then with the crisis, budgets had to be cut, and this got delayed. But there's always something that gets in the way of the investments. Let's hope that this time around, it's not the next big thing, but it is the big thing to do now. So we'll move on to our Q&A. And I don't think we can talk about mental health without mentioning stigma. I would like to know about stigma in Latin American countries and what differences are there. Is there some country that has been successful in reducing the stigma in terms of someone being able to say that they suffer from depression without feeling ashamed of it? It's a very good question, Marco. Certainly, in all countries around the world, Latin America being no exception, in all countries there is the stigma. Mental health and mental disorders haven't yet attained parity in the social sphere in terms of the way people perceive them and how this links to the way people relate to mental health issues. Latin America is no exception, and my feeling is that we haven't invested much. We haven't invested in mental health, and the investment in reducing the stigma is also rather limited. My perception after working with several countries in Latin America is that there is wide variety, as the stigma is very closely linked to other matters, such as certain cultural aspects or social ones. Stigma is not the same across all social classes, nor is it the same across different ethnicities or groups. It is closely linked to the way the mental disorder is perceived. So how it is supposed to originate, where mental disorders are seen from a more medical perspective, the approach is likely to be different to those in which mental disorders are seen as resulting from some form of possession. You know, the anthropological considerations go into this, and accordingly, perceptions are different. But what you say is quite true. So if we don't start leaving all of this behind us, because we're all responsible for the creation of this stigma, if we don't manage to start working towards overcoming this stigma, you know, first of all, people don't want to be identified as suffering from mental health issues. Countries in Latin America have different approaches to dealing with mental health problems in their legislation, in their codes. And this, of course, fashions the way people perceive mental health. For example, today I'm here in Santiago de Chile. The code still refers to people suffering from mental health as insane, which is rather outdated terminology. And besides, dementia is a neurological disorder. But on other fronts, there has been progress in Chile towards reducing the stigma. Laws have been enacted to afford greater protection levels to employees, for instance. Marta asks this, regarding the example of Chile and depression, what kind of training did the women involved in the intervention have, and what were the main interventions undertaken? First off, we work on the basis of the assumption that no one wanted change. So when we used to go in and talk to primary care staff to see what the possibilities were, one thing that always came up was that they didn't want us to implement something that was completely new. They just wanted for us to improve what they already had. So in dealing with depression, there are two classic approaches to treatment. One is medicines, so drugs, and then there's therapies. In the more medical approach, the goal is to find a combination or to see if an individual needs more of one thing or more of the other. And we said, okay, we're not going to reinvent the wheel. We're just going to improve what is already there. And what didn't exist back then was the more conversation related side of it, the therapy side of things. And we went for social workers. This addresses the question on training, and also nurses. And we trained them to provide psychoeducational support within groups so as to help, and also through these guidelines, the women were given an opportunity to come together and share the problems and the issues that they experience. So they would get together a couple of times a week, and if at some point the health disorder was particularly severe, a doctor could see them, examine them, and perhaps prescribe some medication. But it was all highly structured and orderly. And that's what it was, basically. There were also other components that had to do with training people who were in the primary care sector. So we were somehow empowering people who actually had a very different role until then. And this was very powerful because these people who led the groups started to really commit to the work they were doing. And they did help the people in their groups very much. Ricardo, you explained that mental disorders account for 20% of the disease burden, but only 2% of health expenditure. But this 2% of health spending, is it really well targeted in the region? In other words, is the region investing where it should? And what should change in the composition of the spending to address mental health disorders? Great question. And it does have to do with the way we set our priorities. Some things we do know. We know, for instance, that a very substantial share of the spending on mental health, of the 2%, is spent on psychiatric hospitals, the ones that provide care for chronic patients, patients who spend many years there. And the conclusion is that that hasn't turned out to be a good investment. And it's not a good investment from a clinical or humanitarian perspective, and it doesn't seem to be the right path either. And some countries within the region have started to take a different tack, and they've tried to empty the hospitals. Because you see, one very complex thing is that you can't just empty hospitals and chuck the people out into the street. These are people who have spent a whole life there, in addition to their disorders or their disease-related dysfunctions. We have made them even more dysfunctional and more dependent. So we need to pave the way, designing facilities for them according to their functional issues and providing for the required support. But ultimately, the hospital or hospice for chronic patients is something that is being left behind. It is being superseded in many countries. But we in Latin America still allocate much of our mental health budget to these hospitals. Now, once that challenge has been overcome, what could we do? Each country needs to set its own priorities. It's not for me to dictate anything to countries which should set their own priorities based on their own needs. I think primary care in keeping with the WHO concept is where we should have the first filter. And that's where we should be investing most heavily, as it's the first filter. It's an access point, especially for lower income population groups. And that's where people actually arrive. So these primary health clinics should be within the communities, and I would make them a great priority. There are also age groups which have been very much left behind in the region. Youth, for example, both ends of the spectrum of life, both youth, the early phases of life, and also older persons. These are two groups that have been significantly neglected. And this is what I wanted to stress this. When we make the economic case, productivity is important for societies, but beware, some peoples are not necessarily productive, but we have a responsibility as societies for the well-being of these people. Very good.
Ricardo, con estos recursos humanos que
Ricardo, with these human resources we train who are not psychiatrists, starting with what the systems already have to offer, what part of the human resources gap can we actually close? How can we meet many of those needs? And what are the costs involved? Very good question. When I used to present the Latin American experience, and when we started off with this in Chile, when I presented this to audiences in the developed world, I was somehow accused of promoting low quality care as it was not delivered by the specialized human resources. And my answer to that was always the same. I said, well, maybe, but the results we see are the same you find while investing 10 times more than ourselves. So many developed countries started to take an interest in this. And, you know, the task shifting is a very powerful thing in the developed world as well. But I always remind them that we in the developing world have come to this task shifting for different reasons due to a necessity. In the developed world, it has had more to do with saving resources, which are always limited. But both have arrived at the same point. And today, task shifting is widely accepted, so delegating tasks to others. How long did the training of the social workers in Chile last? It's highly varied. When we started off in Chile, we were very scared. It was the first experience of the sort, so we gave them much more training than what is now done in other parts of the world. Perhaps we gave them more training, 2 intensive weeks, but it wasn't just the training that was delivered, but the human resources that get new tasks delegated to them need support and some supervision. It's not just about training and taking off. And as part of the supervision and support, we kept the training process going. They had acquired skills, they had become competent in certain areas and started to focus more on the areas that they were still uncomfortable with. Now, over time, we gradually became more radical. And in some countries in Africa, we would run the training over the course of 3 days with follow-up and monitoring to follow. But of course, it all depends on the role you assign to the resource, the new role, because if the role is fairly limited, the training required is bound to be more limited as well, more than likely. But if the role is more extensive and involves high responsibilities, you need to give the resources more for them to do the job right and for them to feel comfortable. It's definitely a much more efficient way of doing things economically, much more than the way that health services are being delivered in the world right now. A question from Pablo. He says he's heard that mental and neural diseases are the new chronic diseases today. So what about the effective management side of it? And what is the role of prevention as well and protection? Do you think this should be a focus in order to promote investment in mental health too? The answer is yes to both, and let me go into detail. The fact of the matter is that the ideal when it comes to any disease is prevention. In mental health, as in the case of physical diseases, we are still rather far from being able to say that we have very cost-effective interventions. But we're making headway. And we know that most mental disorders start at an early age. Most mental disorders, 75% of them is the figure estimated, they start before the age of 24. It is known that if this is identified at an early stage and interventions take place, that's prevention, secondary prevention. So it's about early identification, early intervention, that in itself is a powerful intervention. Most diseases, mental health disorders are chronic in nature, not all of them, but most of them. So they continue over time, and some remain persistent, such as severe disorders like psychosis. These are disorders that remain over time and that are often coupled with a decline in the functionality of the individual. These individuals become very dependent, and the depression and anxiety or anguish disorders are recurrent, in that a person may experience them, be treated effectively, improve, and then relapse at a later stage. And this is the case very often. There's a relapse, so that the approach to many of these disorders has to consider a chronic disease component. Let us hope we had some more. It would be good if we had some more. And the chronic disease approach is highly relevant to mental disorders. Ricardo, what is the role of digital platforms? And I'll ask another question that is among the ones asked by the webinar participants. Can you help close the gap in mental health care in distant or rural areas? Yes, I chose to leave it for the end to invite the audience not to struggle that much. I know many people don't feel that comfortable with technology. And this is one thing that should be considered. There's a lot into that. There are things related to privacy, access to information, and so on, especially in the case of disorders that carry so much stigma. So there are things that need to be considered. But the fact is that technology is offering an opportunity. In fact, COVID pushed us into this. I started working on this 15 years ago, but COVID actually put it first, right, and center. And this is how it became a necessity to access remote treatment. And the only possibility was to make use of technology. So we did have to experiment a lot with technology. That's the one thing about technology. Since it offers remote access, one of the main challenges we have, especially with specialized resources, is the equitable distribution of resources geographically. Rural areas in all of Latin America have a lot less by way of specialized resources. So technology emerges in different ways and can help reduce the gap in access and offer some level of support to address mental disorders, some level of support. I'm not saying that it's going to resolve it all. Pide Gregorio, what channel, of course, it's hard to say what the best channel is, but just to get started, what about educational establishments focusing on students and teachers, perhaps the health system focusing on patients, or businesses and companies focusing on employees? What would be the best channel? And I'll expand a little bit, although I will appreciate a brief answer. What's the role of the private sector in addressing the mental health gap? I think all of the ones you pointed out are important, all of them, no exceptions. It is hard when you looked at the intersectoral side of it. It's hard to secure the commitment to mental health actions. I've worked a lot in schools, and that's hard because it's a sector that works under pressure. In many countries, teachers are asked to do everything, and you go into schools and say that you'd like to do something to promote mental health, and teachers will look at you and say, look, every day someone comes along with a new idea. We can't cope anymore. So we need to be careful and be really clear in terms of what can be done and how it can be done. It's not impossible, to skip the intermediary. It's not necessary to always train the teacher. You can do something with the teacher, but you can also reach out to the student directly. And technology is a very powerful way of doing precisely this. You asked a second question, Marco, which I now forgot. The role of the private sector. Oh, yes, the role of the private sector. I don't know what private sector is intended. If we're talking about the private sector in the healthcare sector, it's one thing. But if we're talking about the private sector as in the business sector, it's a different kettle of fish. The truth is that here no one is exempted, in that everyone must step in. And Chile has a hybrid healthcare financing system. There used to be a private sector component. It was very thriving and substantial. Now it's less. To a certain extent, the private sector, and probably due to the pressure of regulation, the regulatory framework laid down by the ministries, and eventually things were arranged to ensure viability. So no one is out of this. Everyone needs to be involved. Ricardo, if someone were to seek out an example of a success story in the world that has involved a reduction as much as possible of stigma, or a case in which there's no more stigma, with the best sort of prevention and treatment, what model should we be looking at, or what combination of models for that matter? I don't think there's any country in the world that is free of stigma in mental health orders. The stigma level is different. In some countries, it's more than in others. In Latin America, I think we are still lagging behind in this regard. These stigma levels require truly global social transformations in order for the stigma to diminish. There are some initiatives that are government-led, but it could also be the private sector, and those things encourage a new look at things. If a government says, okay, if someone has a mental health disorder, you can't demand that they come to the workplace. You need to offer protection. So you see, people do start to think about mental health disorders a different way because they wonder, okay, so a mental health issue, is it the same as suffering from high blood pressure or having diabetes? Well, yeah. So this is why I advocate parity. Now, as to whether there's a country with a perfect model, I dare say no. If you look at the United States today, it may not be the most powerful healthcare model to display for poorer countries. But in the States, you can open any newspaper and find the references to the mental health crisis, and it's a services crisis. So it doesn't have to do with the economic development of a country or its GDP. It doesn't necessarily mean that there's a robust mental health problem. Now, Scandinavian countries get it quite right. And again, Scandinavian countries do place a great emphasis on benefits, on social well-being for their populations. So this helps along the way. One last question for a 30-second answer. One more word on the role of communities, please. It's vital. The role of communities is truly vital, as that is where people connect on a deeper level. And if we can reach into that, it will open up 1,000 doors that weren't there before. This is the case of the example I referred to earlier, the women engaged in our program. You know, if you look at how it was 25 years ago, and these women have gone beyond the benefits they themselves received, and they actually managed to spread this across the community. It would be interesting to see if those communities exhibit less of a stigma. Thank you. Thank you very much for this rich exchange on such a fundamental issue as mental health is. We thank all participants in this webinar, and we'd like to invite you to read the bank's Healthy People blog. We'll be sharing a summary of this webinar there, and we'll also be uploading the video of the presentation and of our discussion. So thank you very much for attending, and see you soon.